Thanks very much indeed. When I submitted the abstract, we had 6-month data, but since it's been accepted, we've now got 12-month data from this European study, so I've included that in this talk. This slide just shows you all the contributors throughout Europe, and I see Gus Tang in the audience, I think. Oh, who was also the other UK contributor. The Physio II ring is, I don't want this to be an advert for it, but this is the ring. The unique thing about it is this double saddle shape, slightly more pronounced anteriorly than posteriorly. The anterior part is stiffer than the rest of the ring, so that gives it sort of rather selective flexibility. It's more flexible in the AP diameter than it is in the transverse diameter. And it has this concept of one design fitting all patients. And the way they've done this is that once it gets to 34 millimeters, the ring becomes more spherical as it gets larger to accommodate the larger anterior leaflet that's seen in the Barlow-type valve. The Physio II Registry, 7 European countries, 17 centres, 339 patients, and the time period of the study was there. The 2 UK centres were ourselves and Blackpool. Concomitant procedures, half the patients didn't have anything else done, and you can see there that the rest of the concomitant procedures, tricuspid annuloplasty notably in 16%. Age, this is quite an elderly population. Median age is shown there, 66, and you can see the majority of the patients are actually in the first part of their 8th decade. And women tended to be slightly older than men overall, which I think is perhaps what we see. Carpentier functional classification, as I think we would expect, the vast majority of patients are having this for degenerative valve disease and therefore have a type 2 lesion. The other lesion sets can be seen there. Looking at the mitral valve pathology in type 2, localized tissue excess, which by and large correlates with P2 prolapse was by far the commonest lesion. No excess tissue, which corresponds to just fibroelastic deficiency in the elderly, was the second, and then a Barlow valve was seen in about 15% of patients. Looking at type 2, as we would expect, the Barlow's population are significantly younger than other patients presenting. Interestingly, the no excess of tissue, which we would expect to be slightly older, didn't show that. Ring sizes, the commonest ring size was size 30. If you think back to Frank Wells' talk at the university, he was telling us he was putting in a 33 was the size he said was his commonest ring size. So that's quite an interesting comparison. But as you can see, the whole range from 24, which is really only used in undersizing ischemics, right up to size 40, which obviously is only used in Barlow's. Looking at the ring size and etiology, as we would expect, the largest rings were put in the Barlows, and again, I think as we would expect, patients with fibroelastic deficiency and no excess of tissue had rather smaller rings. And looking at type 2, interestingly, that disappears, perhaps suggesting that it was patients with type 1 and type 3B lesions that were having the small rings, but again, Barlow having much bigger rings. This, for me, is the most interesting slide. Looking at techniques used. A ring only was just used in 20% of patients, and I guess that's only type 1 and type 3B. But if you look at the techniques that are used across Europe in this time frame, artificial cords has now become the commonest adjunct to mitral valve repair, which I think is a testament to Patrick Perrier, who really has publicised this and popularised this Europe-wide. Interestingly, when I was looking at the history of artificial cords, the first reference I can find to the use of artificial cords was by Tyrone David, as with many things. Look at NYHA classification. You can see that as time goes on, patients on discharge, it's quite difficult to judge NYHA classification on discharge, but by 6 months in a year, the vast majority of patients are in NYHA class 1, but there are 1 or 2 patients at 6 months in a year in NYHA class 3, and we can guess why that is. Looking at MR severity, the majority of patients coming to surgery had severe mitral regurgitation, and this is not really, I think, a characteristic of the ring, it's a characteristic of the quality of the surgery, but the vast majority of patients have no or trivial mitral regurgitation as time goes on. But this was an all-comers study, so there are 1 or 2 failures, and as you can see, there's a couple of patients with severe MR out at 1 year. I think I was responsible for 50% of those 2. Looking at, do we get reverse remodeling? Well, yes, we do. You can see that the end diastolic diameters come down at discharge, and that's maintained over the period of a year, which is reassuring. And similarly, end systolic diameter, but far less, partly because the majority of patients coming to surgery do not have dilatation of the ventricle in end systole, because the vast majority of patients have pretty reasonable ventricular function. So we haven't seen such a dramatic change there. Ejection fraction, again, you would expect that to come down because patients with severe mitral regurgitation clearly have the ability to have a much higher ejection fraction if their ventricle functions normally, and that comes down a little bit when you stop that, but there's been no deterioration at all. In fact, a slight improvement in left ventricular ejection fraction over the year. We do obviously make the mitral valve orifices significantly smaller when we do mitral valve repair, so there is a gradient across a repaired valve, but I hope you'll agree that this is relatively insignificant at something like 3, and the gradient stays stable over the year. It doesn't increase, which is reassuring. An effective orifice area, again, this is slightly smaller than a normal mitral valve, something which is certainly a topic close to Frank Wells' heart, but the orifice is adequate for normal function for the vast majority of patients. Remember, most of these are in their 8th decade, so they're not athletes. And again, there's no change. This is stable over the year, which is reassuring. So to conclude, this study really gave us the opportunity to give a snapshot of mitral valve repair across Europe, which was certainly very interesting to find out what's going on. And the use of artificial cords has become the single most popular technique. I hope you'll agree that the Physio II ring is a reliable adjunct to repair and provides good hemodynamics long term. The repairs were stable over the year, and I think we were able to show that one design of this ring does fit all patients. Thank you very much indeed.